that has a specialty in treating patients in a traditional addiction model who have chronic pain. Most of our patients, about 60 to 70% of them, are on prescribed medications. We have a lot of alcoholics and drug addicts too. This is the most important slide. Go to sleep after this. This is the most important thing I've learned, which is that we should be mindful of the fact that pain is not a reliable indicator of tissue damage, and that tissue damage is not a reliable indicator of pain. Pain is very emotional, almost like an emotional body. My patients have taught me that. The Affordable Health Care Act mandated that a national pain strategy be developed. A lot of research was ordered the first few years. It came into being in 2010. And there was one research committee that worked on addiction and pain management. Out of all of them, addiction finally got dropped because it was too controversial, and there were too many things that they could rely on that they could agree on. So addiction isn't really, I don't need to tell you, it's everywhere in the newspapers that opiate abuse and dependence is an epidemic in our country. So here are the other recommendations of the NIH study and the report that came out this year were these multidisciplinary treatment approaches. That one recommendation was the increased scientific knowledge regarding the pathophysiology of pain has led to the conclusion that chronic pain can be a disease into itself that requires adequate treatment and research. Chronic pain is a biopsychosocial condition that often requires integrated, multimodal, and interdisciplinary treatment. Self-management programs, which I'll explain in just a minute, can improve the quality of life and are an important component of acute and chronic pain management and prevention. So we already had developed what we call self-practice. It's a self-management program. I got mad one day. I got on the elevator and this patient, I saw her and I said, well, how's it going? She said, I've almost had a migraine 3 times today. She was in our family program. And she said, but I did my deep breathing and I was okay. And I haven't had a migraine all day. And I said, great, we're doing self-practice. Well, then I bumped into another patient and I say, how's your recovery going? How is your pain management? She said, well, I'm going to join a yoga club, when I get out of treatment, and I'm gonna. And I just blew a gasket. I said, that's it. We are going to develop, 5 or 6 skills, and we're going to teach this. We're all going to call them the same thing. The physicians, the techs, the nurses, everybody. We're going to call these things the same thing. So we came up with these 6 things. Deep breathing, visualization. Okay. So we developed hypnosis scripts on these 6 things. And we use these 6 skills, we repeat them throughout the day, and I even give them a little chart with stars for their door to their room. It's a residential treatment building. And so they can put a star on each one. Now, I have, most of our patients are professionals, and they're very bright, but I can tell you they love to choose their sticker and put their sticker on, so I can walk by and affirm them for what they're doing. So here's this kind of stuff we do. We do mindfulness, acupuncture. You probably can't see that there are needles there. Physical therapy, a lot of what I call comfort giving, yoga, walking, exercising, and then therapy. So one day, I was so excited with this patient. She came from Central Texas. She sees one of the best pain doctors here in town. And about 10 years ago, she had a tumor inside her spinal column, around the top of her neck. And that was very painful. But she was on, and I confirmed this with a pharmacist, because I thought the husband was exaggerating. But their bill for the medication she was on was $1 million a year to her insurance company. What had happened is her tolerance had creeped up over the years to the point she was on Acute, which I didn't even know what Acute was. It is a fentanyl lollipop. They use it for cancer pain. You and I would only see it with our loved ones in their final days. She was on 7 or 8 all day long. She was on so many, her teeth were rotten. If you've ever seen crystal meth addicts. And so anyway, this husband was just hovering. And because of him, she lived. He slept with Narcan on his bedside table. You know, Narcan is the antagonist of opiates that first responders use, that if somebody's non-responsive, that's what you do now, is you give them a shot of Narcan. And we always have at least one patient on our unit who's there because a first responder administered Narcan. So as he's leaving, I'm like peeling his guys like Velcro to get him, go home. And he says, all I want to know is this. What are you going to do and how are you going to handle it when she screams? And I said, Mr. So-and-so, don't worry about it. You know, we are going to comfort her. And you can rest assured that she's going to be okay. We're going to keep as, good a close watch on her as you do. And so he left, and then I thought, holy moly, what in the heck am I going to do when she screams? Here's her repertoire. Not screaming and screaming. Just not a whole lot of skills. So I started thinking, okay, we got all this stuff for chronic pain. We got this down pat. But now we need something for acute pain. And, we're an abstinence-only treatment program. So what I did was I did a literature review. And I found that something called virtual reality plus hypnosis yields really good pain results. And this is the work of Dr. David Patterson, who's famous in virtual reality and in the pain world. And this is a pediatric burn patient. And this is, again, probably y'all have all heard of Snow World. And it's an environment where you go in and it's glaciers and ice, and it's a snow world. And you move the little snowman up the trail. And what they're doing a daily debridement. So they come in and take the skin off. It's very painful, it's very emotional for the patient. So when they start distracting the patient with VR, they have a tremendous reduction in pain. I had a patient yesterday we have VR in our unit, and he's just gone wild with it. And I was saying, that I was coming here to see you all today, and I talked to him about the burn stuff, and he said, well, I'm a burn patient, and he pulled his arm back, and he said, I spent like 4 months in the hospital when I was a little boy, and he showed me, and I didn't even know that he had been traumatized that way. But he has really grabbed onto this. And I've also given you if you want to read it later, some of the research of Dr. Patterson and his colleagues. So, here I'm an old lady. I have no idea what virtual reality is. I know what hypnosis is, but I don't know what virtual reality is. And so I find something called a meetup, and I went, and the guys were so nice to me. They put a headset on me, and they didn't show me the scary, films. They showed me the little floating through space. They were really kind to me. And so I got to understand what virtual reality is. And so Eric, you all know Eric, I'm sure, just a really kind, wonderful man, came and helped put us together what we did. This one of our nurses who's being trained, and I have it right out in the day room because I had this thought that our staff would just embrace this and be excited, but the truth is they're intimidated by all the calibration and everything. There are only two of us that really do it. So I decided, driving in here today, I was going to train patients to do this and do it for each other because we get a lot of young people who are not intimidated by it. So Aaron Limke, a software developer in Austin, wrote this. I'm sure most of y'all are familiar with this, an old software called Eden River. And his approach is to use VR as sort of a support for meditation. And so in this Eden River, it's cartoonish, it's animated, and you kind of float down this river, and then these little birds fly with you, and you just float down the river. And so we wrote a hypnosis script. Houston Community College has one of the best recording studios in the country. They have they're like 7 in the country that's as good as theirs. So we went to them, and what you see there, we did a binaural recording. So we put the microphones in this little styrofoam dummy, and she walked around. And so that makes it, when we have the hypnosis script, it takes it around the body. And so it's more distracting to the patient. And I can tell you that when we first started using this, we get patients, because we're an abstinence-based program, probably half of the addiction treatment professionals use something like methadone or Suboxone or something, some medical treatment. And we use your natural body, and we use abstinence. And so I thought that we wouldn't have any patients that would come to our unit, because here we're going to take grandma, who's been, for 10 years in a recliner, all doped up on narcos, years and years and years of not doing anything. And we're going to tell her, come on into our unit. We're going to take you off your pain medicine, and you're going to feel so good. And I just thought, this isn't going to fly. But I can tell you that my patients have taught me, they all know this. They all know that when we get them off, that their pain is decreased because of a condition called hypoalgesia, which is heightened pain sensitivity that's caused by the opiates, and the rebound. All of our patients come in just to stay out of withdrawal. They're not using it to escape and be in la la land. They're using it to stay out of withdrawal. That's the very final phase of addiction. So we set up this little chair in our day room, and when a patient is going through detox and they are having pretty strong pain, and mostly it's anxiety, because a chronic pain patient has this awful mental mindset that I'm a burden to everyone, no one will ever want me, no one's going to be able to do anything to prove, they have just these, what we call interjects, these totally self-defeating beliefs about themselves and their pain. And we have to change that. I can tell you that when we put a detoxing patient on the VR, they have an experience of believing us that we really can do this for them. Up until that, they're kind of anxious, and they're thinking, oh, they're going to take me off my pain pills. They're going to just, I'm just going to be hurting, nobody's going to do anything for me, which isn't true. So I can tell you that as soon as we do this with a patient, they kind of calm down and they buy into our course of treatment. Any questions? Yes, sir.
So is this something that you prescribe to them, or is there like a regimen? Is it an hour a day or a half an hour per day?
That's a great question. It is not a treatment that will decrease their pain. It's a diversion. It's a distraction. So what it does, if I get on it, it's going to reduce my anxiety, my fear, and so I'm going to have an escape for 40 minutes. And I'm going to get a little hopeful that when you all send me to yoga and do the those bowls, Tibetan bowls, you know, that harmonize, and the acupuncture, and all this stuff that seems a little new agey, they give us a break and they come and they try it. And we have a physical therapist on our unit who's a real physical therapist, all that sort of stuff. And they kind of buy into it that maybe they can do it too. Yes, yes, sir.
At what stage of addiction would you say this is useful? Is it like
Well, just in detox. So there are 100 patients on the other side of the building of our unit. All of them have active addiction. They are in trouble with a lot of misbehavior around drugs and alcohol. Misbehavior. My patients, probably 60-70% of them have active addiction. But there are a whole lot of people, like we admitted just a couple of days ago, a 77-year-old woman whose family just finally picked her up and brought her and said, "You got to stay here." Because she was driving them crazy. And they're in their final phase, but they are chemically dependent and not active addiction. And believe it or not, those are two separate things. Your body reacts differently being chemically dependent, which is I'm just physically dependent on these pills or alcohol, and I have a lot of misbehavior about it. Misbehavior means I write my own scripts, I use grandma's supply when I'm over at her house, I steal, come home. But folks, a lot of the folks that come to us are there strictly because they're going to a pain doctor. They're for years, they're on very high levels of pain medicine, and they need to get off. Yes, sir?
Have you tried this method on patients like, patients with CFS? Chronic fatigue syndrome?
You mean chronic pain syndrome?
Yeah. For instance?
Yes. The only condition that we have treated that we cannot treat is something called stiff man syndrome. And it's where her muscles contracted so bad that it was breaking her bones. Our physicians had only seen one case before, and he was an ER doc in the past. But this chronic regional pain syndrome is something that responds really well. And a lot of it has to do with reducing the anxiety about my condition and accepting that I can have a really great life and I may be uncomfortable. We also teach our patients how all of us, we're getting older, I'm older, we're going to need our knee replaced. How am I going to handle it when I have to go back on narcotics again? So we teach them that. So there's a safe way to go back and then come back and be abstinent again. Yes, sir?
Are there any features or, I guess, for the experiences or the hardware that you hope are developed for this sort of treatment?
Yes, and you're going to hear from her in just a minute on comfort. This young woman right here, or the young woman that did the hypnosis script. I had a graduate student that came, and she was from Belgium. She's absolutely precious. Diane, some of y'all have met her from the meetup in Houston. And anyway, she just went crazy. She was really into hypnosis, and then we discovered together virtual reality. And she took that along with her other partners, this woman and your presenter in just a minute, and they created a company to do this. I only use one software and one script. That's the only thing on there. We don't do any other kind of virtual reality. It's not hooked up to the internet. Patrick Broderick told us that. Y'all know Patrick Broderick, University of Houston Virtual Reality Clinical Lab and Mental Health Center. Patrick Broderick, he's one of the central researchers in addiction and virtual reality in this country. He's right here at U of H, in the School of Social Work. An amazing, amazing guy. Any other questions? Yes, sir.
How do you keep the patient's attention to the virtual reality? Because I mean, get it up that it's gonna feel the pain or anxiety. It's like saying something else. Like how do you manage like for the patient not to take the headset off and say, I'm gonna go away?
You know, I've never had a patient do that. They are so frightened. And here, okay, I'm gonna go back to your psychology course. I have 5 minutes so I can do this. Remember when you took psychology and they talked to you about Vygotsky zone of proximal development? Okay, what that means is, like I had a little boy, I mean, he's still a little boy, but when he was real little, I bought him one of those arrows, bow and arrows, you know, that you got at the grocery store. It has a little sucker on the end of it. And so he put it on, and it would fall off. He put the arrow on it, and it would fall off. And he just was having this temper tantrum. So I went to him and I said, okay, son, let's pick this up. Put out your finger, put the arrow on top of your finger, and then you can shoot it. That's the point where hand over hand, I can do it, but I can't do it by myself. And what I teach our nurses is this is where every patient is when they walk up to the med window. They're saying to you, I have exhausted every skill I have to my pain. Now I need you to medicate me. I have no skills at this moment. And so what we do is we say, let me show you how you can do this. We put him in this chair, calm him down, put him in the comfort room, wrap him in warm towels. We do from them externally what they cannot do internally. And we tell them it's going to be okay. And it is. It is. We're not going to let them be in acute pain. You know, we don't do it that way. And now for the greatest presentation is the next step after this, when y'all get to hear from uncomfort.